This video demonstrates principles of robotic port placement. By applying these techniques, ports can be accurately positioned for any surgery.
So let us suppose we are operating a case of abdominal perineal dissection and the patient is in lithotomy position. This is the head end and this is the caudal end. So imagine if you're operating this patient laparoscopically or in open surgery, the assistant and the surgeon stands on the right side of the patient and the camera person also stands on the right side because we want to ligate the inferior mesenteric artery and inferior mesenteric vein which are accessible from the right side. So the assistant and the camera person stand on the right side of the patient, and on the left side at the foot end comes the screen or the monitor. In robotic surgery, also the position remains more or less the same. The assistant stands on the right side of the patient in a case of carcinoma rectum, and imagine sitting inside the abdomen and operating with your bare hands. I think that is the easiest way to imagine how to place the ports. So if you're sitting inside the abdomen and operating with your bare hands, see this is going to be your left hand and this is going to be your right hand. So from left side to right side, if you see in the console, the ports are from R1, R2, R3 and R4. This is how your instruments are placed. R1 and R2 are in the control of left hand, R3 and R4 are in the control of right hand. And as the assistant is standing on the right side, the patient cart cannot come on the right side because there won't be enough space for both to sit on the same side. So the patient cart comes on the left side. So before robotic port placement, we need to define our surgical workspace and define our target anatomy. So surgical workspace is the area in the patient that all instruments will need to reach successfully to complete the procedure. So in a case of in a case of carcinoma rectum, you will need to reach both pelvis and also the descending colon in case, and also the splenic flexion in case we want to mobilize the descending colon to reach up to the pelvis for low rectal anastomosis. So that is going to be our surgical workspace. The next step is defining the target anatomy. So from the center of this surgical workspace, the target anatomy is the farthest point required to reach within this workspace. This may not always be the location or the site of the pathology. So that was our first step in robotic port placement, that is defining surgical workspace and target anatomy. Now we insufflate the abdomen and the rest of the port locations are marked only on insufflated abdomen, not on the deflated abdomen. The ports are then placed in a linear fashion perpendicular to the target anatomy, and this distance should be at least 20 centimeters. And depending on the patient habitus, it can range from 10 to 20 centimeters. In obese patients, you can go up to 22 to 24 centimeters. Da Vinci system recommends this linear port placement to minimize arm to arm interferences. And these ports should be at least 2 centimeters away from any bony prominence. Now coming to the port placement, so in our right hand are R3 and R4, and on our left hand are R1 and R2, as we can see in this image from the console. So R1 and R2, from left to right, we place the ports as R1, R2, R3 and R4. The arms also come in a similar fashion. It is not necessary to remember this arrangement because as you place the ports, it's automatically going to be like this only. Just remember that on your right hand are R3 and R4, and on your left hand are R1 and R2, as the surgeon is sitting in the console or whether you're sitting inside the abdomen and imagining. And in between the ports, the distance should be at least 6 to 10 centimeters. We take usually 8 centimeters for a normal adult patient. And the assistant ports should be placed in triangular fashion away from the robotic ports, at least with a distance of 7 centimeters. They should not be placed right behind the robotic ports because it can result in interference with the when we are manipulating the assistant port. And we can place the additional assistant port right parallel to it. We preferably place a 12 port on the right side because this is the dominant side and it is easier to place staplers or pass in gauze pieces from the right hand rather than the left hand, and we use one extra left hand port for suctioning out or for traction purposes. So these are the steps, so let's go through them again. Defining surgical workspace and target anatomy, insufflation, port placement, perform a diagnostic laparoscopy before you place all the ports, then place the assistant ports and position the patient. In a rectum case, we need head up, head low and left side up. So prior to docking the robot, make sure that your patient position is ready and the small bowel is moved away from the target site. Now coming to the case in the OR, so we have initially marked our surgical space and target anatomy, then we have insufflated the abdomen. Now we are marking the ports. These ports are marked 20 centimeters away from the target anatomy, each measured at least 8 centimeters apart from each other. The ports should be at least 2 centimeters away from bony prominences. We are using the back of the cannula to make a mark so that the incision that we give does not extend more or less beyond the size of the cannula. This will ensure that they are not inadvertently displaced while performing the surgery. So the first trocar that we are placing is a blunt trocar. We can see the black tip and it is placed blindly. Now we remove the trocar and place the endoscope and visually inspect the abdomen, perform a diagnostic laparoscopy and rule out any distant metastasis. Now the next ports that were placed are sharp trocars because these ports are placed under vision, ensuring that the remote center stays within the abdominal wall. Remote center is the thick black mark on the cannula which has to be placed right in the abdominal wall. Here we are checking that the remote center is placed right. Even for the first port that we have placed blindly, ensure that the remote center lies within the abdominal wall. Next, place the rest of the assistant ports. Now position the patient and also position the small bowel away from the target site. Now before docking, ensure that the pelvic anatomy is selected and this green light, that is the robot, is placed on the patient left side, select patient left. Then press deploy for docking button. So this will align all the arms towards our target anatomy. Then move the patient card to align the green laser line at least within 5 centimeters within the endoscope port using visual cues. Now install the first port. The first port is the endoscopic port. Here in this case it is R2, the second arm. Now we place the endoscope and press and hold the targeting button, that is the leftmost button. Point the green laser point at the desired target anatomy and press and hold the targeting button till the boom aligns itself towards the target anatomy. Next, bring down the rest of the arms and mount over the cannulas. To mount the cannula, press and hold the port clutch button and also the cannula lever on the front. Once all the arms are attached, the next step is alignment and aiming. Alignment is ensuring that there is at least a hand breadth distance between each arm and also away from the patient. And aim all the instruments towards the target anatomy, and that is parallel to the first placed endoscopic arm. Now hold the cannula and quick press and release the port clutch button to release the abdominal wall tension. Now under vision, guide each instrument towards the target anatomy. So here we can see in this video, we are guiding the cardiac forceps and the fenestrated bipolar forceps towards the target anatomy under vision. This is an important step because if we don't place these under vision, we do not have a tactile feedback and there's high chance that you'll injure some small bowel or vessels. So these instruments should be placed under vision always. Once they are placed within the target space, next place the fourth arm, that is monopolar scissors, again similarly guided towards the target anatomy. Once all three arms are in the field of vision, then unclutch the instrument clutch button and give control to the surgeon.